All right. Good morning, everybody. Welcome to Pediatric Grand Rounds. Today's speaker is Dr. Maggie Nelson. Dr. Nelson is one of our third-year pediatric residents. She's a graduate of the University of Richmond and completed her medical training at VTC SOM. While here, she served as the representative to the American Academy of Pediatrics. She also served as one of the third-year chief residents. Her QI initiatives included management of bruit in the emergency room and post-op pain management. Dr. Nelson was inducted in the Gold Humanism Honor Society 2020 for recognition of her exceptional clinical and teaching skills by VTC SOM. Dr. Nelson will be moving to Chicago and working in general pediatrics and will be on faculty at Northwestern University Hospital. Her faculty advisor for today's presentation is Dr. Jeri Lantz. Please join me in welcoming Dr. Maggie Nelson.
Okay, thanks for the introduction, Dr. Permeshwar. Appreciate it. Hi, everybody. I'm Maggie, and I'd like to go ahead and thank a couple people for helping me with this presentation on teen pregnancy and contraception. Dr. Jeri Lantz, my mentor for this, was extremely helpful. Brooks Michael, local educator, who we'll be discussing later. And of course, Dana and Aaron in the teen clinic have taught me a bunch about this topic. So let's get started. Starting with our objectives, we are going to look at the historical trends of teenage pregnancy on a local and national level. We're going to talk about the epidemiology of teen pregnancy and the effect it has on our patients, what is happening locally with teen pregnancy and prevention, the role of the pediatrician in the prevention of this phenomenon, and finally, we're going to do some clinical teaching on contraception and birth control. Okay, so a quick thought exercise, and you guys don't need to chat in about this, but just think about who of you knew somebody in high school that was pregnant or became pregnant in high school as a teenager. Maybe they weren't your best friend, but stats tell us that most of you probably knew somebody who had a teen pregnancy or at least went to class with them. I know that I knew a couple of people in my high school who got pregnant. I don't think they graduated. I don't think they went to college. We had a very different trajectory in our lives. And at the time, you know, they seemed like they were very mature. And now that I'm a pediatrician, looking back, I realize that this is the age of my patients. So thinking about those women and the different trajectories that their lives took was part of the inspiration behind making this presentation. So let's start with some definitions. What is teen pregnancy? This is going to be a documented pregnancy, also diagnosed pregnancy, carried by a teen. And a teen would be someone that's 12 to 19 years old. However, some sources for research purposes only really document 15 to 19 years. The pregnancy itself includes pregnancies that end in miscarriage, elective termination, stillbirths, and live births, but you should keep in mind that postpartum data looking at teens who have gone through a pregnancy often only look at parenting mothers, so those that completed a pregnancy, had a child, and then also kept the child and raised them on their own. So that's only going to be a subset of the initial teen pregnancies. So why do we care about teen pregnancy? How does this affect our patients when our patient is the teen? When compared to pregnant adult females, pregnant teens are going to be at a significantly higher risk for certain complications during pregnancy, such as gestational hypertension, anemia, and eclampsia. Pregnant females are also going to be at a higher risk for domestic violence and homicide during the pregnancy as compared to adults. Also, when compared to non-pregnant adolescents, pregnant adolescents are going to be significantly more likely to drop out of high school. So there's a 40% graduation rate for pregnant adolescents as compared to 85% for the overall population. Additionally, fewer than 2% of adolescent moms finish college by age 30. So how does this affect our patients after birth? Mental health-wise, about 44% of postpartum teens experience depression as compared to 5 to 20% of non-pregnant teens and adult females. Additionally, we worry about domestic violence after birth as well. Unfortunately, a study of over 500 teen moms in the US found that 41% reported intimate partner violence within 2 years after they gave birth. 21% of moms reported intimate partner violence in the first 3 months that they were postpartum. Adolescent mothers overall are 2 to 3 times more likely to experience domestic violence than adult mothers. And then repeat pregnancy is also a concern. So 20% of all adolescent births are of the second order or higher. So how does this affect our patients when our patient is the child? Short-term wise, there's going to be a higher risk of low birth weight, prematurity, neonatal death, non-accidental trauma, sudden infant death, and overall infant death within the first year of life to babies born to teen mothers. This was just an interesting, kind of sobering piece of data that I found when I was looking up, researching for this presentation. Children born to a teen mom who are not the mother's firstborn, so secondborn or furthermore, are 9 to 10 times more likely to be victims of homicide as compared to firstborn children with mothers 25 plus. So it's a high risk population. Long term, you're going to see that children born to adolescent mothers are going to be significantly more likely to drop out of high school, 33% drop out. A quarter of the women born to teen moms become adolescent moms themselves, and 16% of the boys born to teen moms become incarcerated. These differences do remain significant when controlling for multiple variables, including socioeconomic status. So let's look at how we're doing historically. Overall, this is a very reassuring graph. So in the 1950s and 60s, we had a baby boom. You saw 96.3 out of every 1,000 teens were getting pregnant, which is like almost 1 in 10. That has significantly dropped over the years. Our last bump was in 2006 with a consistent drop after that in pregnancy rate. And this graph goes through 2018 when the pregnancy rate was 17.4 out of 1,000 moms. Much decrease from that high of 96.3. Why has it gone down? It's multifactorial, but the thought is that there's been more availability of shorter acting and long acting contraception, and teens are waiting longer to actually become sexually active. Now we felt good about ourselves when we looked at the history, but globally it's a bit of a different story. Unfortunately, the US consistently has the highest teenage pregnancy rate out of all developed countries outside of the ex-Soviet bloc. So you can see here on this helpful graph, which is from 2015, that the United States clearly had the highest teen pregnancy rate out of all the developed countries listed here. Why is that? Researchers have mostly proposed that a major driver of this phenomenon is not something homogenous across the US, but more that there's so much disparity throughout the US. So this was an interesting quote from an economic journal I found, saying that a teenage girl in Mississippi is 4 times more likely to give birth than a teen in New Hampshire, and 16 times more likely than a girl in Switzerland. So where you are and what resources are there and what education is there really drives a lot of this. So let's zoom things down into more of a micro level. How are we doing here locally in Southwest Virginia? Not the best compared to the rest of the state. So you can see on my graph here that we are the green line, which unfortunately is higher than the other regions and when it comes to teen pregnancy rate. So this graph is from 2015. At that time, Virginia's pregnancy rate was 17.1 out of 1,000 females. And that was 12th in the nation, where the lower number is better for lowest rate of teen births. However, in the same year, Southwest Virginia had a rate of 38.4 teen births out of 1,000 teens. And this was the same rate as Arkansas, which had the worst rate in the nation. So let's zoom in a little more and talk about Roanoke City specifically, because Roanoke City has a very interesting history when it comes to teen pregnancy and prevention. Roanoke City, out of 130 cities and counties in Virginia, had the highest teen pregnancy rate in the state in the early 1990s. This led to a lot of prevention efforts, including a state grant, which led to the formation of our lovely teen clinics at William Fleming and Patrick Henry that are actually situated in our high schools, as well as our teen clinic itself. It also led to us hiring our adolescent health educator, Brooks Michael, initially hired from the state grant, and now working through Carilion, who's been in this area for a long time and provides education at the middle and high school level at various schools in this area. These prevention efforts were successful, and from 2012 to 2014, Roanoke City moved out of the top 10 for the first time in 20 years. Rates overall have continued to decrease since that time, but Roanoke is now in the back in the top 10 at the 6th highest rate as of 2019. You can see that here in the graphic on the bottom right. And thank you so much to Brooks Michael for giving me all of this information. Oops. So let's talk epidemiologically for a second here. Who's going to be most at risk for a teen pregnancy? We do know there are geographic differences when it comes to teen births, and rural teens are going to be more at risk. Some interesting data I found showed that from 2007 to 2015, the teen birth rate was lowest in large urban counties and highest in rural counties. And the birth rate from 2007 to 2015 in rural counties did decline, but it declined at a much slower rate than those in urban counties. Foster care is going to be a risk factor as well. So teens in foster care are going to be at least 2 times more likely to become pregnant. Lower socioeconomic status, neighborhood racial segregation is tied to an increased rate of teen pregnancies. Survivors of abuse, unfortunately. So there's a lot of data on this. Teenagers in physically abusive relationships are about 3 times more likely to become pregnant, and they're also at more risk for partner contraception sabotage. Women who report history of child sexual abuse are over 2 times more likely to have experienced a teen pregnancy as well. And then we know that there's a strong graded effect between number of adverse childhood events and risk for teen pregnancy. So the more ACEs that someone develops, the more at risk they are for having a pregnancy when they're still an adolescent. This is more of a thought exercise. So why Roanoke? Why Southwest Virginia? Why do we struggle with this? The way that I see it is that we are dealing with a couple of those different epidemiologic factors that we discussed on the previous slide. So some of our patients we take care of are rural and maybe don't have access to the resources that we have here in Roanoke City and the education that we have. We do care for a lot of patients that are of a lower socioeconomic status. There is a history of racial segregation in Roanoke as well. And, you know, I think that we also have a culture here of teen pregnancy, and this was also vocalized by Brooks Michael and Dr. Lantz, and I was talking to them. You know, unfortunately, we have that vicious cycle of the 25% of teen moms or girls born to teen moms will experience a teen pregnancy themselves. Unfortunately, a lot of the teens in this area think that having a child that early may just be normal, and it's become somewhat normalized in this region. All right, so let's move into what we can do about it. So prevention starting from the very beginning. The AAP and Bright Futures do make multiple recommendations to promote healthy sexual development before the onset of adolescence and sexual activity. So starting early on, you want to just encourage parents to form a nice, safe, secure attachment to their infant so they know what a healthy relationship looks like, and to use anatomically correct terms when referring to genitalia. In early childhood, you want to reassure families regarding normal sexual and gender exploration. And interestingly, I found in some of the research I was looking at that early childhood education at this age, 1 to 4 years, is tied to a decrease in teen pregnancy rates. So encouraging that education, especially in at-risk kids. And then in the elementary school years, you want to encourage and participate in open conversations regarding all sorts of stuff: puberty, gender, sexuality, talk about consent, you know, display patients' body autonomy, talk about the fact that these are private areas when you're examining them, and ask for the child's consent. And then talk about appropriate boundaries and encourage parents to do the same in person, and then increasingly so in this day and age, online. All right, so let's talk about teen education a little bit. It's been shown time and again, and I'm sure you guys are aware, comprehensive sex education as compared to abstinence only is always shown to be superior in research studies. It promotes multiple positive effects, including delay in initiation and reduction in frequency of sexual intercourse, reduction in number of sexual partners, increase in condom use, and some studies actually show that comprehensive sex education is tied to a decrease in truancy rates and an increase in academic performance, which I found very interesting. What is comprehensive sex education? It may include discussions about puberty, gender and sexuality, consent, assault, healthy relationships, STI prevention, and contraception. I screenshotted a kind of a fun article from the New York Times over to our right about one of the fads that's come and gone in pregnancy prevention. So this girl is holding one of those robot babies that you used to take home, and they would cry and cry and cry and make you think you never wanted to get pregnant. So fun fact, these robot baby programs have been getting phased out because they've actually been shown to have either no effect on the rate of teen pregnancy or actually a negative effect where teens were getting pregnant more when they had gone through these programs. So they are no longer in vogue with sex education. All right, so a little bit about, we talked about what's evidence-based. Let's now talk about what people are actually doing. Despite the evidence we just talked about, laws are lagging behind. 29 out of 50 states require some sort of sex education. 15 states say that it has to be medically accurate. 37 states, more than the initial 29, say that you have to teach abstinence education if you are doing sex education, but only 18 require that birth control be discussed. Pediatricians, remember, you can act as a sex educator, so you always want to be addressing this when appropriate with your patients. Just to kind of put into graphical form what I was talking about for this slide, you can see two helpful graphs on your left and your right. On your right, you see in deeper purple the states where abstinence education is enforced, and on your left, you see in deeper blue the states where birth control education is enforced, so you can see which one is currently predominating. So what's it like in Virginia? In Virginia, currently sexual education is required to include discussion of human trafficking, sexual harassment, consent, and genital mutilation, all good things to talk about. Schools do have the authority to choose and approve sexual health and STD prevention curriculum. There is no current law requiring education be medically accurate here in Virginia. There is no current law requiring discussion of contraception, but abstinence education is required. So what about parental education? This is an interesting focus of some research studies in the study of teen pregnancy prevention, especially in areas where adolescent pregnancy may become part of a local culture and the parents don't realize that it's something that could harm their child. A good systematic review in 2012 by Cornell showed that in-person parental education programs regarding teen pregnancy decreased adolescent risk behaviors, increased protective behaviors, and improved adolescent health outcomes. So very reassuring, kind of exciting data about parental education. The hardest thing you're going to see when it comes to this is that there's just a lack of resources to implement these training courses. And then come on, we got to talk about the guys, right? I mean, they're 50% of this equation. Male education is something that the CDC and the WHO have been pushing more for in the recent years. Preliminary research is limited because not a lot of these programs exist, but so far things look promising for efficacy. I listed a couple of programs that the CDC is currently funding for male education for prevention of teen pregnancy. They include motivational interviewing, group-based programs, father-son interventions, a lot of promising research going on right now. So for the guys, we can't forget about them as medical providers, right? Providers are encouraged to talk to them just like we would the women. You want to conduct a sexual history. You want to ensure they have access to reproductive health services, and you want to encourage active fatherhood in the parents of your patients and in your patients who are becoming parents, because we know it is protective for the child. Teen-friendly practices. So the AAP and the CDC both really emphasize creating a teen-friendly practice when you're a pediatrician interested in preventing teen pregnancy. What does this mean? It means you want to have a welcoming environment, maybe some rooms that don't look like they're only for little babies. You want to have teen availability, so walk-in hours, weekend hours. You want to be clear that you are able to offer confidential visits as well as confidential billing. And then you want to really have accessibility to contraception. So if you can prescribe something same day, if you can place a LARC yourself or get them to someone quickly who can do that, that would be best. A lack of barriers. So ACOG no longer recommends that we do pelvic or breast exams prior to starting, hormonal therapy or even STD testing prior to starting pills. So don't worry about that stuff if it's going to make the teens not pursue contraception. And then support. So just having multidisciplinary support to help your teens that are high risk. All right, so let's do a little bit of clinical teaching now about contraception, one of my favorite things to talk about. This is a great graphic by the CDC talking about what's most effective to what's least effective when it comes to contraceptive care. You can see that our long-acting reversible contraceptions are there at the top. Then you've got the pill and injectable and patch and ring as you work further down. And then towards the bottom, you've got withdrawal and keeping a calendar and sponges and male condoms and all that good stuff. This graphic is helpful because it tells us what sexually active US teens are actually using. So you see the condom, which was not the most effective method, is the most popular. Then you've got the pill, and then you've got no method / not sure for 18% of sexually active teens. Some things to keep in mind. Typical use efficacy is different than perfect use efficacy. So typical use efficacy, especially for taking something like a pill, where you might miss a couple doses, is going to be a lot different than taking that pill every day. Also, always, tell your teens contraceptives are not going to have an effect on STD transmission. So you want to still wear a condom and get tested. And then keep in mind that, especially those of us who are graduating, you need to know what the law is in your state for providing contraception, because only 27 states currently allow minors confidential access to contraceptive care. Some limit this only to married adolescents or mothering adolescents. In Texas, I found this interesting. A teen who already has a child is not even considered emancipated enough to obtain contraception. They have to get written parental consent for that. All right, so moving on to the nitty-gritty stuff. LARCs. LARCs are long-acting, reversible contraception. These are going to be IUDs and Nexplanon, or the implant. The AAP does recommend LARCs as first-line contraception for sexually active adolescents and recommends that pediatricians educate ourselves on the placement of LARCs if at all possible, or at least be able to counsel our patients on them. They are going to be over 99% effective at preventing teen pregnancy, and yet they're only utilized by about 3 to 5% of the sexually active teen population. Some exciting studies have found that with appropriate counseling, up to 70% of adolescents choose LARCs. So clearly there's some sort of disconnect here if such a small percentage of them are actually utilizing them. Some potential barriers that have been identified for patient use include lack of patient education, lack of provider knowledge, and concerns over confidentiality. So IUDs, what are they? They are T-shaped devices that are implanted in a woman's cervix. They could be more hormonal or non-hormonal. The hormonal ones contain progestin, which works to prevent fertilization and implantation, and copper IUDs work via local effects to prevent fertilization. They are long-lasting, which is a huge pro, up to 3 to 10 years. The copper are going to last 10 years. They're marketed under the name Paragard. And then you're going to have a couple of hormonal. Skyla is going to be 3 years. Mirena is 6 years as far as length of efficacy. The hormonal IUDs can make women amenorrheic, which a lot of women like. And some patients, if they're really kind of hormone-free ladies, they enjoy that aspect of the copper IUD. Cons of IUDs, some women don't like it being amenorrheic. There's procedural pain associated, and some pediatricians may not be able to place it themselves, may have to send the patient to a specialist. Side effects include worsening cramping and bleeding, especially with the copper IUD, and then irregular bleeding with the hormonal IUD. Expulsion is a possibility, although it's rare, and same for perforation. This is contraindicated in patients who have an ongoing pelvic infection, so you will want to STD test these patients, a distorted uterine anatomy where it does not fit in the cervix, and then of course, if there's some reason they can't be exposed to copper, you would not want to use the Paragard IUD. Moving on to the Nexplanon implant, the other type of LARC. This is a progestin-containing implant that suppresses ovulation and prevents fertilization. It is also long-lasting, lasts about 3 years, and there's nothing to remember to take like a pill. But the cons are that sometimes the teens can be worried that the bump is visible, and again, you have to refer for placement. Side effects are usually local pain and bruising at the site. There can be an association with heavy and irregular bleeding. So if someone's already a heavy bleeder, this shouldn't be your go-to. And then keep in mind that these can break with trauma. So if your patient gets in a car accident, they need to get it checked. Contraindications are going to be breast cancer, undiagnosed irregular vaginal bleeding, or a severe bleeding disorder. Moving on to the shot or Depo Provera. This is a progestin-containing shot that patients receive every 3 months, and it works similar to the other progestin-containing products, suppressing ovulation and thickening cervical mucus. The pro of this is I know a lot of teens that really like this. So there's no pill to remember. It's not an invasive procedure, but of course you have to present to medical care every 3 months. So this is really good for things like our teen clinics at William Fleming or Patrick Henry, where they can just go between class and get it. The side effects for Depo are going to be amenorrhea or irregular bleeding, weight gain, and loss of bone density. But of note, the bone density does go back to normal after the patient is off the Depo. And I did put weight gain in bold because Depo is really the only type of contraception that's been associated with weight gain in the adolescent population, despite pop culture saying a lot about OCPs leading to weight gain. And you're going to see weight gain more in already overweight adolescents. So just something to keep in mind. It's usually not a significant amount of weight. And then contraindications for this would be severe liver disease, hormone-dependent malignancy, not really things that you're going to be seeing in this population. And then a relative contraindication is pre-existing osteopenia. All right, so now we've gone to the pills. OCPs or oral contraceptive pills are pills that contain a combination of estrogen and progestin. Some can also be progestin only, and they work to stop ovulation and change mucus of the cervix to prevent sperm entry, similar to other types of contraception. Side effects are going to be mood swings, irregular menstrual bleeding, headaches, bloating, but they are not tied to significant weight gain in the adolescent population. Contraindications for our estrogen-containing pills are going to be headache with focal neurologic symptoms, uncontrolled hypertension, clotting, or valvular disease. The pros of pills are there's no procedure, they're easy to conceal, you just take a pill every day, and then a lot of teens like their side effects. So it can help with bad cramping, can help with really heavy bleeding, decreases acne and hair growth as well. And then cons are that it's easy to forget a pill. So where do you even start? There's so many pills out there. How do you choose one for your patients? I'm hoping to break it down for you guys to just work on some tips and tricks because I know that we're seeing this a lot. So first you want to think about monophasic versus triphasic. So monophasic means you have the same dose of estrogen and progestin every single day for 3 weeks, and then you have your week of placebo. Triphasic, you're going to have the same dose of estrogen, but vary your progestin throughout the 3 weeks to more fully or more accurately kind of represent a woman's cycle. At least that's how they are marketed. I've been told anecdotally monophasics are usually great for our teen population, especially if you have teens who are missing different doses here and there and taking triphasics, then their dose may be all over the place. So usually I'm going to default to a monophasic, but you can consider triphasic in teens who have a lot of cyclical symptoms where they're always having bad cramping or something like that at a specific time in their cycle. So you can think about it for those patients. Then when do you want to use your progestin only pills? So you're going to think about that for patients with your estrogen contraindications and breastfeeding patients, but you have to think about the cons. So progestin only pills are going to be less forgiving for missed pills. You got to take those pills within a 2 to 4 hour window, and there's going to be more breakthrough bleeding on those pills as well. Then you got to choose a dose of your estrogen. So you got low, about 20 mics, and then moderate dose, 30 to 35. We don't really do high dose anymore. So low dose estrogen is going to be basically like you just want the birth control. Moderate dose is going to be that they also want the side effects. They want it for their acne or what have you. Now I want to talk about a couple of specific brands. So Seasonique, which is also levonorgestrel ethinyl estradiol, is a moderate dose estrogen, and it's the only pill that's marketed for Q3 month period. So 2 months of just straight pills, and then 1 month of the regular pack with 3 weeks and 1 week of placebo. You can do this with any type of OCP, but you may run out of prescriptions too quickly. So you would want to think about this type of pill if you have a patient that hates having their period because they have really bad pain or really bad bleeding. Then you have your drospirenone containing products, or Yaz and Yasmin. Drospirenone is a subtype of progestin that does not break down into an androgen. So it's really good for patients who have androgenic symptoms like acne and body hair. It's also the only pill that's marketed for PMDD. But you should keep in mind that this does have some spironolactone effects, so you want to avoid it in renal insufficiency. All right, and then a couple of other tips and tricks about OCPs. How do you start someone on one? First of all, just find a pill that's covered by most insurances, and it can be your go-to, a monophasic, and then estrogen dose depending on whether they just want it for birth control or want it for the side effects too. Sprintec is a pill. I know it's brand name, but it's a brand that tends to be covered in this area. And then think about when they want to start it. So there's 3 different ways you can have a patient start pills. You can do Sunday start, first day start, or today start. Sunday start is going to be start the pills next Sunday. First day start is going to be start the pills on the first day of your bleeding. And today start is go home and start taking that pill today. Sunday and today start, the ones with asterisks by them, are the ones where you need to counsel patients that they have to do 7 days of backup birth control, basically condom use, if they are going to use those types of starts. First day start on first day of bleeding, they do not have to use 7 days of backup birth control. Have a patient use an app on their phone to track their periods. Our patients love apps, right? Who doesn't? This graphic is an example of an app called Clue that's really helpful, helps you track when your period is and remember to take your pill. And then for missed pills, what do you do? We're all going to miss our pills at some point. Nobody's perfect. So if someone misses a pill during week 1, you want to take, for any missed pill, an active pill ASAP and backup contraception for 7 days. And then if this is during week 2 or 3 of the cycle, if there's only 1 or 2 missed pills, you take 1 active pill, discard placebos, and just start a whole new pack, but you don't have to do backup contraception. If there's 3 or more missed pills during these weeks, you have to do the active pill, discard placebos, and start a new pack, and use 7 days of backup contraception. So remember that there's a little bit of a difference based on what week you are, and week 1 is kind of the most crucial week where for any missed pill, you have to use backup contraception. All right, moving on to a couple of other forms that are a little less popular, but still out there. So the patch, or marketed by OrthoEvra, is an estrogen and progestin containing patch that patients change weekly for 3 weeks and then take a week off. You do not want to place this on breast tissue. It's a pro because you only have to remember to take something once per week. It's not invasive. Some patients may worry that it's visible. It can cause some skin irritation and bleeding irregularities, and you're going to have headache plus with aura, clotting, and valvular disease contraindications. And also remember that this is not effective in obese patients or patients over 250 pounds. There's an absorption issue and it's not going to be effective. So you cannot prescribe it for those patients. Then the ring, marketed under NuvaRing, although a new ring actually came out that Dr. Lantz was telling me about that is good for a full year, Annovera, so that's exciting. This ring is inserted every 21 days into the vaginal canal. It contains estrogen and progestin, and it works as a form of contraception. It's a pro because you only have to remember something every 21 days. It's a con because, teens will worry about something being in their vagina and potential personal partner discomfort. This ring can be removed and put back in. Technically, it can be removed for up to 48 hours, but a lot of sources, especially for adolescents, recommend leaving it out for only about 3 hours. Side effects are bleeding irregularities, increased vaginal discharge, and headache. And contraindications are going to be your same estrogen contraindications: headache with aura, clotting, valvular disease, uncontrolled hypertension. And now let's talk a little bit about a very important subject, emergency contraception. So about 2/3 of US teens do report having sexual intercourse by age 19, and 11% of high school students report having experienced a forced sexual assault, unfortunately. Emergency contraception is for unprotected sex, missed contraceptives, and sexual assault, and it can significantly reduce chance of pregnancy if it's given 120 hours after sexual intercourse. The sooner the better. Surveys show that a majority of pediatricians and pediatric residents do not counsel patients on emergency contraception or prescribe them. I personally have never prescribed one and didn't know a lot about EC before this talk. While ECs are available over the counter, studies show that patients may still not utilize them due to lack of knowledge and cost concerns. So just in 2019, the AAP did release a statement on emergency contraception advocating that pediatricians provide education about and prescriptions for emergency contraception as appropriate. And it's important to note that there really has been no data showing that increased access to emergency contraception increases risky sexual practices or leads patients to abandon their chosen form of contraception. Just to familiarize everybody a little bit with different types of emergency contraception, the first is Olipristol, marketed under the brand name Ella. This is a progesterone agonist antagonist and is prescription only. It prevents binding of progesterone and therefore just basically prevents ovulation. Menstruation onset may be later than expected, so you want to counsel your patients on that and tell them if you don't have a period within 3 weeks, go ahead and take a pregnancy test. Then we've got the one that most people know about, levonorgestrel or Plan B. This is available over the counter, but it can be quite expensive. It's a high dose progestin, and it delays ovulation and may actually cause next menses to come sooner. You want to abstain from sexual activity or use protection until the next period. And then we've got combined hormonal pills. This is a method where a patient can take 2 to 5 oral contraceptive pills within a 12-hour span. It can be kind of uncomfortable. It can cause nausea and vomiting. And technically OCPs are not approved for this, but ACOG has recognized their effectiveness in basically as a high dose pill and therefore emergency contraception. And then finally, you have Paragard or copper IUD implantation. This is going to be the most effective form of emergency contraception, and it also works as long-term contraception, but of course will carry the side effects of a copper IUD. Some special populations that I want to make sure we touch on. So transgender males, so those that were born female and have transitioned to male, even those that are currently receiving hormonal therapy or testosterone therapy are still at risk for adolescent pregnancy and can become pregnant. These patients are already high risk because transgender people have a 50% lifetime risk of being sexually assaulted, unfortunately. And of course, if a transgendered male were to have an unplanned pregnancy, this would likely heighten feelings of gender dysphoria and depression. So for these patients, you want to approach them just like you would anyone else. You want to be very respectful. You want to, of course, call them by the pronoun that they are supposed to be called by, and limit pelvic exams if you can. Counsel these patients, and you can offer them any type of birth control. Nothing is contraindicated, but some transgender males may prefer to not have hormonal options. And just remember to be a positive force with these patients. A third of transgender people report a negative experience at a doctor's office in the last year, and 23% avoid going altogether to the physician due to these concerns. So just remember to be accepting. Refugee teens, we are a refugee resettlement area. So I found some interesting studies in this area. PCPs discuss and provide contraceptive care for refugee women at a significantly decreased rate compared to non-refugees, while this population actually has a higher rate of unwanted pregnancies than the general population. And in a way, I can understand why you might get tripped up here. We're trying to be appropriate. We're trying to be culturally respectful. There may be a language barrier. We may not be sure what we're supposed to talk about, but we want to make sure that we are trying to be respectful, but also providing all the same contraceptive options to our refugee patients so that we can prevent an unplanned pregnancy in this population. And then, of course, teens in foster care. I know I've treated a lot of teens that are in foster care or foster centers, like our local Intercept Center here. Unfortunately, if you're a teen and you're in the foster care system, you're going to be a lot more likely to be in a center rather than a stable home. I'm sure you guys know, I've seen patients like this in the teen clinic and other outpatient centers. Sometimes you see a patient that's coming into Intercept and they've been in 3 different centers, 4 different centers in the last year. They move, they have a different PCP every time. So it's going to be really hard for these teens to be taking a birth control pill and be getting regular refills. So I would advocate that we really think about long-term birth control for these patients if they desire it, and counsel them on long-acting reversible contraception such as IUDs and Nexplanons, because that will probably decrease their anxiety when it comes time to refill that birth control pill. And what do you do when a teen does become pregnant? So keep in mind that teens are at much higher risk for unknown pregnancy than adults. So you want to screen early and often by getting that pregnancy test done in the office. When you have a positive result, of course, it is confidential for that teen, but encourage them to share it with supportive family members because at some point it will come out. And then you need to refer them to appropriate care. So our Carilion OB-GYN on Jefferson will see patients regardless of insurance. Planned Parenthood in Roanoke provides emergency contraception as well as abortion services, but of note, parental consent is required in Virginia for minor abortion. And then the Blue Ridge Women's Center is helpful for adoption resources. Of note, they do not refer for abortion or discuss that with patients. So you want to make sure that they're going to the appropriate place based on what they want. Remember that the age of consent is 14, so consider a CPS report based on the age of the partner and based on what happened. And then it's really important that these patients not be lost to follow-up and that their care continues. So in addition to OB, they need to have a PCP. If you're not comfortable seeing patients that are pregnant or postpartum, then the teen clinic is a wonderful resource and sees a lot of adolescent mothers. Okay, and this is just kind of something that I thought might be interesting to discuss, the effect of COVID on teen pregnancies in our area. The WHO, or World Wide Health Organization, has projected that school closures and lack of medical care due to COVID-19 will lead to significantly increased teen pregnancy and child marriages in developing countries. But here in the US and in other developed countries, I think the effects will be more nuanced. So social distancing has provided more protection as far as teens not getting together. But then, of course, there's been worsened access to medical care because they're not coming into the doctor and they're not at school where they may have an in-school clinic. So that may decrease contraception use itself. The AAP has already warned us, and I think anecdotally, a lot of us have seen that there's been an increase in teenage depression during the pandemic. And of course, depression and other mental health issues are accompanied by riskier sexual activity. So that may affect our teen pregnancy rate as well, and only time will tell. So where do we go from here? How do we wrap this up? We know that data shows that adolescent pregnancy leads to worse maternal and child outcomes, and therefore reducing teen pregnancy has and will continue to be a major public health concern for decades. Overall, these efforts have led to a significant and progressive decrease in US rates since the 1960s, but there's still a significant amount of teens getting pregnant, especially in specific areas such as our own. And the US really is lagging behind other developed countries in how many of our teens are becoming pregnant. Prevention can be addressed in so many areas: in school, through the education that we discussed; at home, through parental education and support; and in our own offices by us facilitating open conversation and encouraging evidence-based education and access to contraception. What can we do? We can try to maintain teen-friendly practices, really educate ourselves on contraception and emergency contraception, and offer comprehensive and confidential care. If anyone is interested in this topic and wants to get more involved, especially in the local area, there are a couple things you can do. So we need to become personally educated. Unfortunately, a lot of the research that I saw about pediatricians shows that a lot of pediatricians aren't comfortable with different types of contraception, with talking about long-acting contraception, emergency contraception, and I learned a lot of this for this talk too, so I'm guilty too. Pediatrics and ACOG, the journals, have a lot of great articles, many of which I've cited in this presentation, that can get you more information on these topics if you're interested. And then there's actually, if anybody's interested in LARC placement itself, and becoming trained on that, which the AAP does recommend, there are multiple programs that I've listed here. Community education is also key. So Brooks Michael, our adolescent health educator, has brought students and residents with her to do education in schools, and she said that she'd be more than willing to do that again if any of their trainees are interested in that. And then there's also areas to improve here. So Brooks did mention to me that she'd love more longitudinal student education because some schools she can only go to for a day. We don't have parental education programs, which Dr. Lantz and I were talking about and think would be great in this area. Male education programs. So, think of something you think our area could need. And then advocacy. So we talked a little bit about legislation, about laws not advocating for what is evidence-based in sexuality education. So try to advocate that on a local and regional level if it's something that you believe in. Okay, and I'm going to wrap up with a quick question for you guys. So which form of contraception is recommended as first line for teens? You can go ahead and chat in your answer. Reversible contraception. Great job, guys. And now I will show you my references. There are a lot. And I'm happy to share this with anybody that wants to learn more about this topic. And then finally, just some cute pictures. Thanks to my family and my dogs for being comic relief, and everybody that's mentored me through the process of making this grand rounds and through the last 3 years. If anybody has any questions, feel free to chat in or unmute yourselves. So Dr. Fulton, Thank you so much for your comment. He says that it's important to focus on the very low number of states that require science-backed sex education. Yes, I was pretty astounded by this as well. And Virginia is also not one of the states that requires that we teach what's medically accurate. So Dr. Fulton says, I counsel parents on this fact to encourage their education at home. And as doctors of teens, we need to be educating our patients as much as able. I completely agree. And after working with Dr. Fulton out at the Daleville office, I know that he really emphasizes that as well as confidential care for his patients. Dr. Keys also asked a question earlier about the ring that dwells in the vagina for 21 days and if there's associated with toxic shock. And thank you for Dr. Lantz for answering that there is no association with TSS. Yes, Dr. Ward, thank you for your comment. I did have a slide on male education when it comes to teen pregnancy, and I do think that they are half of the problem and yet not very focused on. Instead, it's all about the female and what she should have done. So I completely agree that male education should be part of teenage pregnancy prevention, and the WHO and CDC have been focusing on male education recently and have been funding multiple male education programs. The data is limited because not a lot of these programs exist, but so far we have seen some efficacy. And Dr. Benslevin says that Roanoke County does teach science-based sex ed, which is great, woo. But we do still have schools in the area that have abstinence-only education. And that's what I received in North Carolina, just as a personal anecdote.